Hi, everyone. My name is Brett Sperry. I'm a cardiologist at St. Luke's Mid-America Heart Institute in Kansas City. And we're going into our next talk here in this series on cardiac amyloidosis, technetium pyrophosphate, nuclear imaging. And this talk here is on interpretation and reporting. And here are my disclosures. So for the next 15 or so minutes, I'm going to speak about the appropriate use for bone scintigraphy, how to analyze planar and SPECT images, and then how to produce a comprehensive report. Just to frame things a little bit with a case, 70-year-old white male, symptoms of leg swelling and dyspnea with recent heart failure hospitalization. When we look at the echocardiogram, we see increased LV wall thickness in the septum and posterior wall, so we're starting to think about cardiac amyloidosis here. And is it appropriate or not appropriate to order a pyrophosphate scan or bone scintigraphy in this type of patient? Well, luckily we have two excellent papers, part 1 and part 2, that were put together by multi-modality and multi-specialty groups here, led by ASNC, on technetium pyrophosphate and bone scintigraphy and multimodality imaging in general in cardiac amyloidosis. This is a multimodality imaging paper here, and I'm going to call your attention to part 2 of this document. And these are the different tables that are in this document. First, we have echocardiograms in the appropriate use criteria. The second, we have cardiac MRI. And the third, we have bone scintigraphy. And these are the clinical scenarios going down through which we may find that it's appropriate or rarely appropriate or maybe appropriate for these different indications. So for this patient we just saw, we have a non-African American who's age over 60 with unexplained heart failure and increased LV wall thickness. So here it would be appropriate to do an echo as well as a cardiac MRI and technetium bone scintigraphy. And that's what we'll be talking about for the rest of the talk here. Just to look at some of the other common clinical scenarios that you may encounter where you would consider bone scintigraphy. This is identifying cardiac involvement with no symptoms. So we have asymptomatic gene carriers where that's appropriate. And then we have patients who have AL amyloidosis or concern for AL where it would be rarely appropriate to do a PYP scanning. The next here is evaluation of biopsy-proven AL. Again, here rarely appropriate to do any PYP scanning there. And then evaluation of biopsy-proven ATTR cardiac amyloidosis. And here we don't have data. We don't really have data. And so currently this is listed as rarely appropriate for nuclear bone scintigraphy for things like quantifying the amyloid burden, assessing response to therapy. In those scenarios, it would be rarely appropriate, but hopefully with more data and different techniques to quantify amyloid burden, we may see some of those change in the future. Then follow-up testing, TTR gene carriers and ATTR amyloidosis. If there's new or worsening symptoms, that would be appropriate for nuclear scintigraphy, but for AL would not be appropriate. And then other clinical situations here, it may be appropriate with unexplained bilateral carpal tunnel syndrome and with bicep tendon rupture and with unexplained neuropathy. So for this case that I mentioned here, we do want to do technetium pyrophosphate nuclear scintigraphy, but we also want to make sure that we're ruling out AL amyloidosis with serum kappa and lambda free light chains and serum and urine immunofixations. And then as far as how to read, interpret, and report these studies, there are, again, multiple documents here led by ASNC that you can look at. Part 1 of this multimodality imaging document has a lot of information on this, as well as the ASNC practice points on this. And all of these have been updated little by little as new data has come out because this is a rapidly evolving field. So for PYP image interpretation, historically, there's really 3 components to a report. First is looking at the planar image That's, as we've seen in some of the prior talks, that's the image on the top right there. That is like the chest X-ray type image. From that image, we can assess the semi-quantitative grade or the perigenic grade. That's how it was originally described. And then we can look at the heart to contralateral lung ratio, which is just drawing usually a circular region of interest over the heart and then mirroring that over the contralateral lung and taking the ratio. What I'll say about that is, after seeing many centers grading and quote diagnosing patients with amyloidosis based on planar alone, I really think as a community we need to stop talking about planar imaging and really just focus on the SPECT imaging. And with SPECT imaging, we're looking at the visual uptake in the heart to see, in the chest to see if the uptake of the radio tracer is in the heart or if it's not in the heart, if it's in the blood pool and in the blood vessels. And then the distribution, is it apical sparing? Is it involving the right ventricle or the atrium? Some new data on that recently. So looking at the SPECT imaging really is where you are going to, that's how you're going to interpret these studies. And then at the end, a statement noting that this test does not rule in or out AL amyloidosis. So I will talk for just a couple of minutes on these planar measures because they are still in the guidelines there. For the grades, grade 0 is absent myocardial uptake, grade 1 is less than rib, grade 2 is equal to rib, and 3 is greater than rib. And in some of the documents, they talk about, okay, grade 0 is negative, 1 is indeterminate, 2 and 3 are likely ATTR. I want to get rid of that. I don't want people watching this to really be focused on that because there's so much overlap, particularly in grade 2 and grade 1 with studies that can be positive or negative. So really, we should not be determining whether someone has cardiac amyloidosis or not based on the planar image. Here are some examples of this. Grade 0 on the left. Here's an example of what we call a grade 2, and then grade 3 on the right. Higher grades, in theory, more myocardial uptake, and you see relatively less bony uptake. And then the heart to contralateral lung ratio we talked about. One of the original studies on this looked at a ratio of 1.5 and found that was able to differentiate between AL and ATTR fairly well in a limited number of patients. But as we've done this more and more frequently and expanded this to people that we're questioning whether or not they have amyloidosis at all, we found that there's a lot of overlap between around this number where this is not a sensitive or specific enough number to grade. So again, I would not use planar imaging. I would not use heart to contralateral lung ratio to decide if someone has amyloidosis. I think we need to move away from that. We need to move towards SPECT. Visualizing, is the radio tracer localized to the myocardium or is it in the blood pool? What's the pattern of uptake? And then look for extracardiac findings, obviously, rib fractures, usually other bony lesions are things that you can see. Here are some examples of SPECT. The patient on the left, clearly you see this horseshoe shape that is what the heart looks like. Here we've done SPECT CT, so we have the overlay of the SPECT pyrophosphate image on top of the CT image, so you could really use attenuation correction with CT, and you can tell exactly where the uptake is with respect to other chest structures. And then on the right, you have, again, you see the heart, but you also see the left ventricle very intensely there, but you also see some uptake in the right ventricle. Just a couple examples of that. Here's a good example of why we're not looking at just the planar images, because on the left here, you see a ratio over 1.5, so that would be considered positive. On the right, you see less of the heart there, but you still see a ratio of almost 1.4. And the 3-hour ratio has been considered to be greater than 1.3 is positive, but this is actually a negative study. You look at the SPECT here, and you don't, in the middle image, you don't see anything in the myocardium. So this is a negative study despite a positive ratio at both 1 and 3 hours. This happens more than you would expect. So again, looking and making the determination based on SPECT. There are some new data looking at quantification of SPECT and potentially calculating SUV based upon this. This is from the group at Cedars, and there are ways to do this with both CZT cameras and sodium iodide cameras. This is called the pyrophosphate activity is what they've termed this. But these types of things are on the horizon where maybe we can start quantifying the amount of uptake on SPECT and maybe following that over time, and then maybe change some of these appropriate use criteria to be able to use pyrophosphate longitudinally. Just want to call attention to the IAC standards. These were just published in August of 2021 of just what should be included in a PYP report. We have image quality, visual scan interpretation, semi-quantitative grade, and then conclusion should include overall interpretation and a statement talking about appropriate lab testing to rule out AL amyloidosis. My issue with this, again, is the fact that when we talk about the semi-quantitative grade, that has historically been an assessment of the planar images, which is something we want to move away from. Some people are using the semi-quantitative grade on the SPECT images to say, okay, is the uptake in the heart muscle less than the rib, equal to the rib, or greater than the rib? To me, that is also confusing because sometimes the ribs have various hot spots, and so what exactly are you comparing this to? I think we sometimes make this too difficult. My thought is look at the SPECT images. If you see the heart, it's positive. If you don't see the heart, it's negative, and just make it really easy for people. Here's an example of what the guidelines would like us to put in a summary report. On the planar images, the ratio that's been, and you put the number of hours after the radio tracer was injected. So for example, here, this patient got imaging at both 1 and 3 hours. And we describe the ratio at 1 hour, we describe the grade at 3 hours, and we describe the findings on the SPECT image showing that the radio tracer had diffuse uptake in the myocardium, and then a conclusion saying this is consistent with ATTR cardiac amyloidosis, provided that AL has been ruled out with testing for a plasma cell disorder, something along those lines where you're letting people know that you need to evaluate for AL because we think in some data up to 20% of patients with AL cardiac amyloidosis can have pyrophosphate uptake in the heart. And you don't want to call this ATTR when someone actually has AL. The prognoses are very different and the treatments are very different, which we spoke about in one of the earlier talks. And so that's it for this section here. And we'll have one more section after this, but thank you for listening.